Over the last 30 years, remarkably little has been done to document the history of financial, therapeutic, and operational policy with respect to addiction and behavioral treatment. As part of our mission, C4 has developed a series of films capturing this important oral history.
I think you're a better practitioner today if you can appreciate what this field has come through and what this field has had to overcome in terms of public sentiment. The stigma associated with this, as powerful as it is now, is nothing compared to what it was.
Ray Tamasi has over 40 years of experience managing treatment, intervention, and prevention services, and is a frequent speaker on issues of policy and the redefining of the addiction treatment and prevention system. He was a member of Massachusetts Governor Charlie Baker's opioid working group, and in 2017, the governor appointed him to the Special Commission on Behavioral Health and Prevention. Ray Tamasi is the 2015 recipient of the National Council on Behavioral Health's Visionary Leadership Award. In 2016, he was named a Behavioral Health Champion by the National Council on Addictive Disorders and received the Father Martin Award for Professional Excellence. Ray Tamasi is a member of the Executive Board of the National Association of Addiction Treatment Providers.
Well, it actually began in 1972-73, really I think the birth of the field. A lot of growing pains, but it came about essentially because of the passage of the Hughes Act in 1971-72 during the Nixon administration, where essentially the decriminalization of public intoxication. People were trying to be moved from a judicial system into what they were calling a treatment system, take care of a healthcare issue, and so states began to establish, at that time, detoxification units with money that was available through the feds. The feds tied the money to an amendment that said if you don't take this money to begin to develop systems of care, you won't get this highway improvement money. So everybody said, yes, we'll do it, because they wanted to improve the highways. But nonetheless, that was the impetus for starting the beginnings of a treatment system. And I happened to be at a point in my life where that seemed to be a thing that I was interested in doing, and had association with individuals who were in recovery. And so one of those places turned out to be on Cape Cod. There was a small group of Cape Cod's folks who were advocating for funds to start a detox center on Cape Cod. And there you have it, really. There was very little beyond simply saying, let's do this. And then it's sort of like, let's do it, let's start it, and then we'll figure out actually how to do it after we start it. So that was the beginning, and here we are. We now have gone through a number of iterations of that. The existing detox system still harbors vestiges of that which was back originally. But back then, most of what we were dealing with were primary alcohol-dependent individuals, and many of them were coming through the criminal justice system. In other words, it was essentially folks that were, as we came to understand, well advanced in their disease, generally had burned through much of opportunities in their lives. They were pretty disenfranchised from folks, and they were essentially, as far as the government was concerned, sort of a nuisance to the criminal justice system. So we, of course, were very enthusiastic about how we were going to change all that and turn everyone into an upstanding, sober, functioning individual. We didn't really know the extent of what we were dealing with, but we learned very quickly. I mean, frankly, there were no really good medications to treat alcohol withdrawal, so individuals who came into that detox would very often go into the more acute states of alcohol withdrawal with delirium tremens. And so after a while, after you've seen certain things happen, you begin to say, well, maybe there's a better way to do this. And for me, basically, that question personified my entire career, which was maybe there's a better way to do this. Even when we got to a certain point where we thought we figured out how to do something, I would say to my staff, maybe there's a better way to do this. And I think that sort of philosophy punctuated a lot of what the early pioneers in this field thought about. How do we make this better? How do we ensure that someone doesn't come back every 3 or 4 days? How do we begin to impact? And that's sort of how the system began to get built. It was really quite, I would say, organic growth. There was those original dollars which states said, okay, here's some money, get a detox going. I don't think they really thought beyond that, but we recognized pretty quickly that you can't just do that, because the detox, as I termed it much of my career, is really the emergency room for addiction. And so without funds, but only with the knowledge that we had to do something more, we opened up. There was a vacant floor in this building that they gave us to do the detox in, and we decided to use it to help people stay longer. They could go to this next floor and it could stay 25, 30, 40 days. And we started to see some improvements, but all of that was done without resources. I think it's very important for folks who are doing this today to understand that much of what they're doing today was born 45 years ago, mostly out of the commitment and the passion and the drive to want to help suffering people. That's what really the driver was. There was no money in it. We scraped along. We had a building that apparently had been a nurse's residence on this campus of this hospital, which hadn't been used for many years. And when we said, well, we need a place to do this detox, they said, well, you can't come in the hospital, but you can go in this house, basically, that hadn't been used. And we went in there, we thought we were in heaven. This is great. This is really our place, right? In retrospect, it was a rundown house. But such was the sentiment in the communities and in the healthcare field about individuals who suffered with addiction, that the stigma was very, very powerful then, and certainly it still exists now, but we're at a much better time. So over the years, then we began to build out services as we saw needs arising. And I think it was 3 or 4 years after the detox opened, we thought that women should probably be treated in a setting that was more specific to their needs. And so we started a women's residential program. We added a men's residential program. We started to do some things for women who were pregnant. This was back in the middle 70s. All of this in the early days was funded through government funding. There was no insurance. No insurance company would pay a nickel for any of this. It wasn't until the late 70s that Blue Cross became the first insurance plan that would cover detoxification treatment. So with that, you then saw an explosion of programs, because now you could get paid for it. So now you had not only individuals who were committed essentially to the betterment of the patient, but you also had individuals who said, gee, this is a kind of an easy way to make, a dollar. We can help people and we can make a profit, and there's nothing wrong with that. So you began to see these programs that at the time were, had amenities and had little glitzy things, and what happened because of that is that we began to see bifurcation of the treatment system. So you had places that were supported by government funding. That's pretty much where the lower middle class, the indigent population, those who didn't have resources went. And then you had these other places that didn't really want to treat those individuals because they couldn't pay. And you had folks that had insurance plans, and they went to the nice places. So you had these places for the less resourceful, and you had these places for the other folks. That's kind of how the system developed over the next probably 12 to 15 years. Until such time that insurance companies who were paying for the care in those settings began to realize that their costs were ever increasing, and that there was very little evidence, really, that a month-long stay in a rehab was efficacious. They then began to see this kind of thinking extend to other areas of healthcare, and the outcome of all of that was the savior at the time, which was going to be managed care. We're going to help you manage the care of the patients so that they are in the proper settings, for the proper length of time, et cetera, et cetera. It became very apparent very early that the misnomer was managed care, because it really was about managing costs. It became a period of significant conflict between the programs that were offering their services for insured patients and retaining them for 4, 5, 6 weeks, and the insurance company, who was then saying, well, we don't want to pay for 4, 5, or 6 weeks. We think the patient is okay after 2 or 3 weeks. So the net result of that was many of the private for-profit programs went out of business, ostensibly because the profit margins were no longer there. Insurance companies were reining in lengths of stay. They were constraining reimbursements. You could be in a network, and this is how much you would get. All of this is happening, as I like to say, on the sidelines of healthcare. Addiction treatment was always really sort of over here. I remember once getting a call from a physician in an emergency room. He said, Ray, I have an issue with your admissions department because we have one of your people here. And I said, well, you mean you have one of my staff in the hospital? He said, oh, no, it's not one of your staff. It's one of those people who you take care of. And I said, you mean you have a patient in your hospital? So this mentality of these are not really patients, these are whatever, people who sort of can't get control of their lives. We don't take care of them in the hospital. You do that over there, and usually over there was not near the hospital. So this separation, I think, in retrospect, I understand why it happened and how it happened, but I think it was not to the advantage of the patient and high-quality healthcare. There are many great programs that developed over the years, and they're still around. They do great work. But we had this sort of sideline next to healthcare, not really in healthcare. And that's sort of the way you were paid. There was very little room for innovative approaches because basically you have to have somebody, you do a service that somebody pays for. So the battle over that with managed care extended into, well, until 2008. It's amazing to think that it's more than 10 years ago that President Bush signed the mental health parity bill, and we're still looking for parity. The opioid crisis has changed a lot of minds about that, but it's been an epidemic that has forced some of those changes. So you had the sort of infrastructure of programs over the years, and you had the other side of this, which was, where is the workforce going to come from? In the early days, because there was no field, there was no formal training protocol, most of the individuals who began in this field as counselors and support staff were individuals who were in recovery. And so if you had gone to AA and you were in recovery and you could talk AA, then you became a counselor. And nothing wrong with that. It worked great for a lot of people. But then we began to see that there's a little more that's involved. And so you had the advent of training programs to the point where today now you have certificates, licenses, credentials that are required, courses of study, training, and opportunities to improve your understanding of this disease and how to treat it. I still think it's in its infancy, but we're making progress. We're making progress. Unfortunately, it's taken a series of tragedies to really wake up America to the magnitude of this crisis. And it's not just a crisis of opioids, it's really a crisis of addiction, and it's been going on for many, many, many years. How we gain legitimacy in the eyes of not only the public, but also the larger healthcare system, I think is important for the future. Because in my view, ultimately addiction treatment needs to be integrated into the larger medical system, into the healthcare system. It's a disease, it should be treated as a disease, and there should be the competency and the resources and the commitment of a full system of care to the betterment of the patient. I mean, and this disease is not simply a matter of going in, staying in a hospital for a week and then going out. It requires attention to long-term recovery. It was many years, Jim, before we began hearing words like a chronic management of a disease for addiction. We talked about service pieces, but they were never really linked in any thoughtful way. And what does that continuum look like? And what is a lifetime of recovery look like? I always used to be struck by the question when someone would say, well, what's your success rate? And, that used to be a question that was, you really couldn't answer it. Like, what do they mean by the success rate? How many people come to you and then they never drink again? And, for many years, I think the field was defensive about that until we began to understand more clearly that this is a chronic condition that a person has for their whole life. And then we began to talk about it in terms that healthcare individuals understood. And I think, seeing that this is very similar in terms of how it's managed over the course of a life to how we manage other chronic conditions is very, very important because, let's face it, it doesn't go away. And, we don't criticize patients with diabetes if they have a blood sugar incident. We simply come back and say, how could we have done this better? What do we do next? How do we modify the medication regimen? And so often with addiction, someone would be doing well for a while, they would have a setback, and the response would be either that person really doesn't care, so why should we waste more resources on them? Or the treatment programs are no good because people go there and then they drink again. I think we could have done a lot better if we had sort of captured this much earlier and began to talk about it much earlier as a chronic condition. But there are a lot of things we didn't know. We didn't know about the neurobiology of addiction in 1973 or 74. What we knew is that generally people went to AA, and if they kept going to AA, they might get better. And the ones who didn't go to AA, well, they stopped going, so what else was there for them? And in a sense, we even blame the patient. What did you do wrong? Well, I stopped going to meetings. Okay, so now why don't you go to more meetings? Okay, I'll do that. And then you come back 2 months later, and what happened? Well, I didn't call my sponsor. So there was always this, who was the responsible for the regression? Is it the patient who didn't follow the protocol? Yet we don't really talk that way with individuals who have lapses in their hypertensive disease. We don't bring them in and then berate them about not doing certain things. We try to help them adhere to a regimen. I think that shift is really critical and critically important, because the message to the patient is that we're with you. As I used to say to folks, when you come to Gosnell, we're with you for the life of your recovery. And I really meant that in two ways: for the life of your recovery, for your life, but also for the life, the animation of your recovery as an impetus for you to live an enriched and meaningful life, and to develop and maintain relationships that are important to you. So those factors early on were difficult for us to assimilate, because frankly we were dealing with situations that were always emergent. At any point in time in the original 20-bed detox, we'd have at least a third of the patients who were in active delirium tremens. And let me tell you something, that's no easy condition to manage in a freestanding detox unit. So we've come a long way since that. I dare say there were folks that worked for me back when I was the CEO who had never seen a case of delirium tremens in the detox, who had never seen a seizure. I mean, in the beginning, you'd have 10, 15, 20 seizures a week. So we've understood how to pharmacologically manage withdrawal. And I think we're learning also now that in order to help folks sustain long-term recovery, we need to be attentive not only to the times that they are in a hospital or in a rehab, but how to help them get sort of reintegrate. And I'm not talking about folks that don't have anything. I'm talking about the entire population of addicted individuals, to learn how to be connected to them, to stay engaged with them over time. So we've seen, I think, a lot of advancements. It's come because of the hard spade work of individuals who really did this because a lot of them were grateful that they were sober. I mean, it's as simple as that, really. And I think the giving and the appreciation for that, I think, is terribly important for us going forward, because we're now in a time where I think we'll begin to see much closer integration of addiction treatment with general medical care. And, much of that, there's a lot being said now about, well, the system's fragmented, the rehabs don't work, it's not great, who's doing evidence-based, who's not doing, who's an abstinence-based guy, who's a medication guy. I was always intrigued by that, because I always said the abstinence-based people who were anti-harm reduction, that you do harm reduction every day. We did harm reduction every day in our programs. Not that we were condoning certain things. We weren't a needle exchange program, but we were trying to reduce the harm that addiction causes to people, both physically, emotionally, and socially. And so, and to the medication adherence, I'd say, it's important for the full panoply of services to be brought to bear. Medicating somebody and giving them medication alone, while important and necessary as a component of a plan of care, isn't the only thing to be done. I mean, when I think back, we had no idea how to even medicate folks in withdrawal. I remember once we went to a seminar because we were having so much difficulty with that. There was one guy in the state of Massachusetts who was using medication in very large dosages to manage alcohol withdrawal. And I remember going to that with our medical director at the time. We were trying to learn how to do this better, and we were just shocked by what this guy was saying, because it was unheard of, the number of the milligrams of at the time Librium that were being given. but we began to implement those protocols, and we saw a reduction in the level of acuity in these patients. So it was a learning experience, and fortunately, along the way, there have been individuals who have been particularly influential. This particular guy, Dr. Frank Iber, who worked at the Shattuck in Boston, was the only guy who really knew how to medicate, and he taught people how to do that, and he had a tremendous impact. And over the years, there have been those kinds of folks who have made a difference. So I think one of those things that I see now, unfortunately, is a presumption on the part of some of the folks that are in this field now, and often they don't call it a field now. They call it a business, or they call it the behavioral health space. I like that's particularly intriguing. I think you're a better practitioner today if you can appreciate what this field has come through and what this field has had to overcome in terms of public sentiment. The stigma associated with this, as powerful as it is now, is nothing compared to what it was. And I can tell you that much of the stigma is experienced by the individuals that are practicing this craft. I think it's very important for new folks. I just did a thing with some young individuals who are looking at going into the counseling field. So there's some very important things, and one is to get in touch with how stigma has affected your own impression of individuals who are alcohol or other drug dependent, because we all have that. It sort of grew up with us. These people, the jargon and the terminology that has been used in this field over the years has been very pejorative. And so I remember telling my staff, we're no longer going to use the word addict here. We're no longer going to use the word alcoholic. We're not going to talk about dirty urines, because, for instance, if you have diabetes and you go to your doctor and you have a urine test and it shows a level of sugar in your blood, he doesn't walk into the exam room and say, you have a dirty urine. So those kinds of things were built into the way we grew up in this system, and it took a real thoughtful consideration of how even that terminology characterized people as less than. And it makes it very, very difficult to engage with individuals. And so there are so many little things that we've learned over the years that I hope resound now with people that are working in this field. And I think they are. We're seeing, I look on the Twitter feeds of certain medical places, and we're talking about this as a disease, even though many people don't really believe it's a disease. We're understanding more about the implications of certain areas of the brain that make it a disease. I think all of that information is terribly important in helping not only to educate people, because it takes more than education. It takes a shift in your attitude and your impression of folks who have this condition. It's really a culture shift. And so we're getting there, but it's taken a long, long time. When I finished university, I worked in the business world. The last job I had in that life, if you will, was for a Fortune 500 company in New York City. But I was a product of the 60s in a way, and I began to think about, well, what am I really doing? I was doing my own thing at the time, which was complicating things for me. But when I had a moment of truth and a realization that I wanted my life to be more, to be of more value to, not just to myself, but to other people. And And I just happened to be very, very fortunate when I'd never been to Cape Cod in my life. I'm from New Jersey, so we go down the shore there. So I came here at the suggestion of some friends. I was, as you might say, between careers, and took a position to start a little drop-in center for kids. And then right around that time, in the early 70s, was the birth of the alcohol detox system. And because I had actually worked with kids for a couple of years, basically by instinct, and I had some experience with the recovery movement, I got a job as a counselor. And of course, I went back to school. I got a graduate degree and all of that. But I think, coming into the field at that time for me just happened to be I like to call it a providential experience. It really shifted my life from what can I do always for me to how can I be of service to other people, and I'm not saying that any kind of like saintly way. But it also gave me great gratification, and I loved the opportunity to sit with individuals and families who were in recovery, who were struggling with recovery. What I didn't like was, fighting with insurance companies or really spending a lot of time trying to justify our existence. That's a sad moment in our country's history, I think, and we're still sort of working our way out of it. So. For a long time, I never really thought about my impact. As I got near the end of my career, and people started to give me lucite things, and I wondered, like, why am I getting these things, and why am I being recognized for things? I think if for me, what was most important was, it's a strange way to say this, was dissatisfaction. And by that I mean, I had this thing, and I attribute this to the ethic that I got from my mother and my father, that no matter what we did, I was always driven by the thinking that said, how can this be better tomorrow? What can we do better tomorrow that we're doing today? And then listening to patients and listening to families, and then trying to respond to the needs that were reflected in their concerns by saying, we have to do something to try to remedy that. And it's very, very difficult in any business to take on things that don't have a realizable resource, capital resource, that don't have realizable, sustainable funding. And I didn't think about this until after I had retired. That drove me, and I happen to have the good fortune to have enough people around me who were similarly committed, so that if I said to my inner circle, and that was not always my senior management staff, but my inner circle of thinkers, I'd say, I really think that if we ought to think about starting this or that, because it may make it easier for people to stay in recovery longer. I had folks that were willing to say, I'll take that on, I'll be a part of that. And so, it was 2011, I think, that we began doing recovery coaching, 5-6 years ahead of the curve on that. We started trying to integrate clinical people into medical practices in 2003, 2004, because I said to myself, that's where patients are. They're seeing their doctors. If we can get to them earlier. So it was always that drive to want to be part of some idea that advanced recovery or advanced care. And I had, again, the good fortune of people who were willing to carry that ball, who were willing to come back to me and say things like, Mr. T, that idea you had it's a good idea, but we've been doing it now for 6 months, and it could use something else. And I'd say, okay, what does it need? And we would add that in. It was really an exciting, to me, that was the great excitement of working in this field, is that we always try to maintain some of that sort of pioneering, innovative spirit. And that's what got me there every day. Because I just tell my people, I'm not really a believer in burnout. I still am not, actually. I understand that people get tired and they get, beat up by this, and I certainly did. But if you can sustain the passion, stay in touch with your own inner self, and continue to believe in what you have to do, and commit yourself to it, to me, that's a legacy. How many family meetings have I sat in and seen the pain in those family members, and realized that even we did interventions. We do interventions and we train the family, and we get them to really focus on this one moment in time. We're trying to get Bill to say, "Yes, I'll go," and then Bill would say, "Okay, I'll go," and everybody would be happy and hug, and Bill would go, and then that family would be left there. You can't walk away from the interconnectedness of that, and the sort of the foul roots of addiction, and how it affects the immediate and the extended family. I don't know that the fullness of that has been grasped yet, because even though we talk about this as a chronic disease, I don't know if the impact of a patient with diabetes on his family is the same as the impact of one with addiction on his family, because of the widespread destruction and the sort of disintegration, if you will, of loving relationships. My hopes is the future is that this treatment is fully integrated into our healthcare system, with individuals who understand the neurobiology of addiction, who are engaged in research to really find ways to affect long-term recovery, and to have this condition married, if you will, to doctors who understand it, to nurses, to hospital administrators, and to social workers and therapists who are working together to affect recovery. I don't see long-term survival in the standalone centers exclusively, although there will always be the need for those, and also earlier intervention. We have historically waited for patients to get to the point where they see no other option but then to make that call that they haven't been wanting to call for 5 years. So they call a place and they're in crisis, and they have to get into a bed today, and there are never enough beds. There will never be enough beds to deal with immediate needs. So earlier intervention, identification, testing, and the readiness of the medical community to start having these conversations with their patients in an open and meaningful way, not simply in a cursory manner where you kind of run through the screening questions, do you smoke, do you drink, do you do this, and then on to the real problems. I think that day is coming. I think it's coming not because the healthcare system is sort of enamored with trying to figure out addiction, but I think the healthcare system is being driven now by the way they will be paid in the future, and what their responsibilities will be for trying to maintain the health of a population of people, regardless of what their condition is. So, again, as in many areas of this of healthcare, is that innovations will come as part of considerations for financial risk, or financial reward. The last thoughts, I guess, are reflective thoughts. And I guess thoughts for me, of gratitude for having been given the opportunity, which I didn't purposely seek, but which came to me out of what I saw at the time as a darkness and despair, and what turned out for me to be not only a different life, but also a life of meaningful service to society. And those are easy words to say, but when you step away and you retire, I never really liked the word retire, but when you step away and then you think back about what your life has been, it's been a good life.